So hello everyone, welcome to the UNC Core Center for Clinical Research 101 Introductory Series for June 24th, 2020. We appreciate you joining us for today's talk. Our presenter today is Dr. Beth Jonas, the Chief of Rheumatology, Allergy, and Immunology Division here at UNC. Her presentation today is titled Approach to the Patient with Joint Pain. Dr. Jonas, whenever you're ready to start, feel free.
All right. Thanks so much, Council, and thanks for inviting me to present this session for this morning. This talk is really geared toward our student learners who are with us for the summer, and so I want everyone to sort of jump in if they have questions or anything that they want to ask as we move along. I'd like to keep it pretty informal. So, you know, musculoskeletal pain is probably one of the most prevalent complaints that people have when they visit a physician, not just a rheumatologist or an orthopedist, but a general physician, a family doctor, internal medicine, urgent care. And so, you know, understanding the approach to the evaluation and management of patients with musculoskeletal pain is very, very important. So one of the first things you want to ask yourself when someone comes and says, you know, this or that joint is hurting me, is really where is the pain coming from? I think this is very important. So sometimes a patient will come and say, my hip hurts, or my knee hurts, or my shoulder hurts. And the first thing that we're thinking about often as rheumatologists and really as general practitioners is that the pain is really coming from the joint. And that may be true. But you also want to ask yourself, could that pain be coming from another structure that's supporting the joint, such as the bursa? And in this picture on the right, you can see there are a number of bursa. This is a knee, obviously. You know, there's a prepatellar bursa, there's an infrapatellar bursa, and many other bursa that may become inflamed and tender or even infected. That may be the source of pain. The muscles that surround the joint may be the source of pain. Any tendons or ligaments that insert on any of the bones of the structure may be the source of pain. Or even the pain may be referred from another structure. For example, someone who has diaphragmatic irritation or a pleural effusion may present with shoulder pain, or someone with hip disease may present with knee pain. So I want you to think very broadly when a patient comes and complains about pain, you know, where that pain might be coming from. And your history and your physical examination will help you sort that out. The other issue is, what is the quality of the pain? Pain from arthritis is often described as an achy pain, but not always. It can be sharp in some cases. Joint pain is often associated with stiffness, and sometimes patients don't really articulate the word stiffness very well, and so I will offer that word, you know, is your joint stiff? And then sometimes the light will go on and someone will say, yeah, it's not really pain, it's not really aching, but it's stiffness. And when stiffness is prolonged, it's generally a symptom of inflammation. Not always, but in general. Sometimes the patients will have pain that has a burning quality or numbness, and this may suggest a neuropathic cause. So for example, somebody may present with hip pain that has a burning or numb or shooting kind of quality. And yes, this may be coming from the hip itself, but I also want you to think, could there be a nerve that's being irritated in the lumbar spine that's radiating around to that hip that causes that pain? Again, the quality of the pain may suggest where the pain may be coming from. Sharp pain, or pain that's associated with locking or popping of a joint, is likely to be mechanical or traumatic. For example, somebody who has acute onset of knee pain or locking of the knee or popping of the knee may have a meniscal tear or some other internal derangement of the knee, which is not arthritis per se. Now, sometimes these things can overlap. You can have arthritis and then have a traumatic or mechanical derangement. Sorting that out can sometimes be a bit tricky. But the quality of the pain can often help you distinguish what the possible etiology is. Other clinical features of joint pain may include the duration, How long has it been going on? Is it acute or is it chronic, persisting for weeks or longer? The number of joints involved, is this monoarticular, one joint, oligoarticular, or polyarticular? If more than one joint is involved, as it often is in chronic arthritis, is the joint pain symmetric or asymmetric? So, is the hand on one side and the hand on the other side both involved, or is it one knee or two knees, and so on? It's very important when you're evaluating your patient, both doing your history and your physical exam, to very accurately delineate the joints that are involved, because the patterns of joint involvement, which joints are involved, how many joints are involved, symmetry or asymmetry, can often send you down a diagnostic path. And then one of the other major features of joint pain is the presence or absence of inflammation. And this can be also very tricky. We've traditionally classified arthritides as inflammatory and non-inflammatory. And maybe some of the diseases such as osteoarthritis that we have traditionally called non-inflammatory are actually pretty inflammatory. We're just not looking in the right compartment. But the pattern that patients present with can often send you in the right or sometimes off your path. So how long has the pain been going on? This is very important. So acute pain generally has been present for hours to days, subacute pain, days to a week, and then chronic pain, generally weeks or longer. Certain forms of arthritis you're not going to consider until they become chronic, such as rheumatoid arthritis. Certain kinds of arthritis may present more acutely, such as acute rheumatic fever or infectious arthritis or things like that. Again, how many joints are involved? Monoarthritis, obviously, one joint is involved. Oligoarthritis is defined as 2 to 4 joints, and polyarthritis greater than 4 joints. And so this should be familiar to everyone, the cardinal signs of inflammation: rubor, tumor, calor, and dolor. Rubor being redness of a joint, tumor, swelling of a joint, calor, heat, and dolor, pain. These are the cardinal signs of inflammation and are very useful as we're thinking about our patients who present with rheumatic disease. Is the joint pain inflammatory? So, there are a few questions you're going to ask your patient. Does the joint swell? Most of the time, inflammatory joint pain is associated with swelling. Does it feel warm to the touch? And you can use the back of your hand is probably most useful in assessing warmth of a joint. So you'll see the rheumatologist and other clinicians touching a knee or a wrist or a shoulder with the back of their hand can be very helpful in delineating. And then you want to compare side to side. And then, has the patient tried any medications, and which ones? So certain medicines might be very helpful. Response to NSAID is not necessarily specific for inflammation, but response to steroids might be. So if a patient has been treated with steroids and the pain got a lot better, suggests that there was an inflammatory cause. And you want to ask patients, what have you tried? Did it work? And that can often help you down your pathway. Other questions on your medical history that are important is the joint stiff in the morning? The vast majority of patients with inflammatory joint disease will describe stiffness that's worse in the morning and gets better with a little bit of activity. You want to document the degree of stiffness and the length of time that it takes for the joint to become as limber as it's going to be for the day. And most patients with inflammatory arthritis will have stiffness that lasts greater than an hour in the morning. And this really should be going on for weeks or sometimes even months at a time, to definitely say that this is inflammatory. But patients with the most severe forms of inflammatory arthritis will say they have many hours of morning stiffness. And sometimes a patient will look at you and say, that stiffness really never goes away. And that can be very helpful information. And other questions like, what time of day is the pain worse? So sometimes when you're taking a history from a patient, you don't want to really lead the witness. So instead of asking, is the pain worse in the morning? And that's a yes or no. You might ask, what time of day is the pain worse? And almost uniformly, patients with inflammatory joint pain will say that the pain is worse in the morning. Sometimes they'll say the pain wakes them up at night. And if someone tells you that, that's kind of a red flag sign for inflammation. And if they tell you that their back pain wakes them at night, that's also a red flag sign either for inflammation, infection, or cancer. And so, you know, joint pain that wakes you at night should really be an important piece of your history and make you want to look much more further into the etiology of that. The response to exercise or rest, inflammatory joint pain is often better with some exercise. So patients will say they get up in the morning, they have a lot of pain or stiffness, they get in the shower, they move around, they may go for a walk, go up and down stairs, do whatever they do in their morning routine, and then that inflammatory pain gets better. Patients with osteoarthritis or non-inflammatory or mechanical pain will say they get up in the morning, their joints feel okay, then they start to get moving and using their joints, and then later on in the day, the pain gets worse. You know, these are not hard and fast rules, but can help you on your way to assessing the patient and making a diagnosis. So this is just a useful little chart to look at signs and symptoms of inflammation and non-inflammatory joint pain, and we just went over most of this. One of the other things to think about is systemic symptoms, and in rheumatology, many of our diseases don't involve just the joints, but they really involve the whole body and many other organ systems, and fatigue can be a very, very important indicator of systemic inflammation. So inflammatory joint pain, such patients with rheumatoid arthritis or psoriatic disease or ankylosing spondylitis or lupus and things like that, will often present with a lot of fatigue. It's unusual for patients with non-inflammatory types of musculoskeletal problems, such as internal derangements, osteoarthritis, to have a lot of fatigue. The onset is often variable in both types. We talked about morning stiffness, we talked about morning pain, and then response to exercise. And in terms of your physical examination, signs of inflammation that are most specific will include synovial hypertrophy. And this is not something you can learn on a Zoom call. You really have to get into the clinic and evaluate patients and really touch their joints. But you know, an experienced clinician can feel synovial swelling around a joint. It often has a sort of doughy and gummy kind of feel about it, and I like to describe it as the consistency of a very fresh gummy bear. So those of you who have small people or in your life or other people with sweet teeth may know that consistency of synovial hypertrophy is the consistency of a very fresh gummy bear. There may be a joint effusion, which may be free-flowing fluid that you can palpate or see, particularly around large joints such as the knee, and there may be erythema and warmth around the joint that may be signs of inflammation. Other less specific signs would be joint tenderness, which may be prevalent in many different kinds of joint problems. Pain with motion, particularly at the extremes of the range, can be seen. And then in long-standing disease or where there's a large joint effusion, there may be limitation in range of motion. But the synovial hypertrophy, warm joint effusions often are the signs of inflammation on your physical examination. So next I want to talk about some patterns of joint involvement. There may be involvement of the peripheral joints, so you know, hands, wrists, elbows, knees, ankles, and feet are your peripheral joints. The involvement, as I mentioned, may be symmetric or asymmetric, and then there may be involvement of large or small joints or both. And again, when you're taking your history and doing your physical examination and doing your assessment, you want to make a notation. Is it peripheral? Is it symmetric or asymmetric? Is it large or small joints or both? And then involvement of the axial joints, so the spine, cervical, thoracic, lumbosacral spine, and the sacroiliac joints. And there may be axial joint disease, such as in ankylosing spondylitis, but there may also be axial joint disease with peripheral joints, and so some patients with spondyloarthropathies may have peripheral joint involvement also. So again, is there involvement of the axial skeleton plus or minus involvement of the peripheral joints? Again, that's another thing that's going to help you sort of categorize your patients with joint pain. And then the pattern of joint progression. So joint pain often starts in one place, so it's unusual, although not impossible, for patients to describe, the acute onset of a polyarthritis or an oligoarthritis, but more often than not, someone will say, my knee started to bother me on Wednesday on the left, and then by Friday, the right knee was bothering me, and then, so things start and then they evolve. And so talking to the patients, if they can tell you sort of how it started, can be very helpful. So we sometimes describe a pattern of an additive joint progression. So it starts in one place and then moves to include another joint and then moves to include another joint. But the early joints continue to be involved. So many kinds of arthritis can present like this. RA is probably the classical one, where it sort of starts in a wrist, then may involve the hand, and then go to the other side, and then eventually it presents as a symmetric polyarthritis. And then some patients may present with an arthritis that's migratory, and sometimes patients will say, I think you're going to think I'm nuts, but my right wrist started to bother me, and then the right wrist got better, and then it went to the left wrist, and then the left wrist got better, and then to my right ankle, and so on. Again, for no apparent rhyme or reason. They haven't overused or injured or anything like that. It's just moved around. And there's some forms of arthritis that classically present like that. And two examples would be acute rheumatic fever and gonococcal arthritis. So if someone gives you that history, that should make you want to think about those kinds of things. And acute rheumatic fever, although we think about this occurring primarily in the developing world, actually is on the rise in the United States. And we've seen quite a number of cases of acute rheumatic fever here over the last few years in the medical center. So let's move on and talk a little bit about some particular patterns of joint pain. And first, we're going to talk about an acute monoarthritis. And acute monoarthritis is really septic until proven otherwise. So anytime someone presents with an acute arthritis in a joint, swelling, pain, stiffness, redness, then you really want to be thinking about an infection. But as I mentioned in the last slide, oftentimes what's going to turn into a polyarthritis starts in a single joint. So you have to have that on your list of things to be concerned about also. But septic arthritis and the other major form of arthritis, probably even more commonly than septic arthritis, is a crystal-induced arthritis such as gout or pseudo-gout, can present as an acute monoarthritis. The classic presentation of gout being a painful, swollen, great toe, but it really can involve any other joint, particularly lower extremity, ankle, knee, but it can really start anywhere. A reactive arthritis can present as an acute monoarthritis, but may turn into an oligoarthritis eventually. Plant thorn synovitis, which is very rare. I've seen it just a handful of times in my career, and usually the patient will say, I was working out in the garden and I got stuck by a thorn, so it's not generally a big diagnostic dilemma, but it can happen, but it's rare. And then other infections besides acute bacterial infections, mycobacterial infections, viral infections, other soft tissue infections. Those infections tend to be not quite as acute as the bacterial infections, And then the other major category of acute monoarticular joint pain would be trauma or an internal derangement. So obviously, if someone falls and injures a joint, you would get that in their history. They may have a hemarthrosis, which may be due to trauma in the joint, or a patient who has a bleeding diathesis may present with a hemarthrosis. Stress fractures can occur. Sometimes patients will have fractures of the tibial plateau, which can be, have very little trauma, and they can present with joint pain. And then loose bodies, or obviously meniscal tears or other internal derangements of the soft tissue of the joint may present with a monoarthritis, classically the knee, but not always. So when you're approaching this patient, obviously you want to ask about trauma. That's the easiest thing to start with. Did you injure yourself? That's usually pretty easy to get at, unless the patient is drunk, and we see this. Sometimes a patient's inebriated, falls down, and then they don't recall having injured themselves. Your physical examination is going to be very helpful. X-ray and other imaging modalities can differentiate some of these things. You want to ask about signs and look for symptoms and signs of infection, fever, other localizing signs, leukocytosis on their CBC, and then think about risk factors for crystal-induced arthritis, such as a previous history of gout or pseudo-gout, presence of chronic renal disease, which may put somebody at risk for gout, and then a previous history of kidney stones, which might be a clue to somebody who would be at high risk for crystal-induced arthritis. But as I mentioned a couple of slides ago, acute monoarthritis is septic until proven otherwise. And I think I've now said that 3 times. And so I had a professor in medical school, Dr. Robert Rohner, may he rest in peace, who said, if the professor has said that 3 times, it's probably something you need to know. And we will say this again and again. Someone presents with a swollen and tender and inflamed joint, you really want to be thinking about an infection. And in this case, an arthrocentesis is absolutely essential in the workup of an acute monoarthritis. So you want to aspirate that joint and take a look at the synovial fluid, primarily to rule out an infection. And so this is what your synovial fluid may look like. So on the left panel, you see a normal synovial fluid, which is clear. And if there was a piece of paper behind that, you should be able to read small type through that synovial fluid. Patients with osteoarthritis may have some inflammatory cells, so it may just look a little bit less clear. Inflammatory arthritis, you should not be able to read through. And then septic arthritis really looks like pus in a tube. So this is purulent synovial fluid. Septic arthritis can look like this. And in some cases, and many cases, patients with crystal-induced arthritis may have a synovial fluid that looks just like this. Sometimes, if there's blood in your synovial fluid, and it's very common when you're aspirating a joint to get some blood, it may actually look like cream of tomato soup. So if you aspirate cream of tomato soup, that's something else you want to be thinking about, infection or other inflammatory joint diseases. So your synovial fluid analysis is very important, and in the clinic we'll often just take a drop of fluid and put it on a slide and take a look at it at the microscope right in the clinic. We can just look at it under sort of a regular microscope, and also use our polarizing microscope to look for crystals. Patients with septic arthritis will have more than 50,000 cells per cubic millimeter, and you can actually count the cells on the microscope. I'll show you that on the next slide, and sort of estimate the number of cells that your Coulter counter will count in the clinic, in the lab when you get it there. Septic arthritis generally does not have crystals, and it's usually culture positive, but not always. So about 10 or 15% of the time, even in patients who have septic arthritis, the culture is negative, either because the organism is hard to grow, somebody may have had antibiotics, and so you may not be able to grow it in your culture. Rheumatoid arthritis often has a cell count greater than 50,000, and it can be even higher than that. Generally, crystals are not seen, although I'll show you a picture. Actually, maybe I don't have that picture. Sometimes you'll see cholesterol crystals, but that's extremely rare. Culture should be negative. In gout, again, the cell count should be inflammatory greater than 5,000 cells, but many times it's way higher than that and can be even in the range of a septic joint. You should be able to see monosodium urate crystals, and the culture should be negative. Patients with osteoarthritis may have an elevated cell count, but it's generally less than 2,000 per cubic millimeter. You should not see crystals, and the culture is negative. Sometimes we'll see patients who've had intra-articular steroids put in their joint for one reason or another, and if you aspirate that joint soon after that, you will see crystals that can look like gout. So you want to ask your patient, have you had arthrocentesis and injection of any medication into that joint, when you're evaluating that patient, because you can be sent off by that. So this is an inflammatory synovial fluid that we're just looking at under the light microscope, and you see just really sheets of inflammatory cells. These are predominantly polymorphonucleoleucocytes, and you can see that the nuclei are sort of bi or trilobed here. There's a couple of lymphocytes, but this is a predominantly neutrophilic inflammatory synovial fluid. And you don't see any organisms, obviously, on this slide. You will have to stain for organisms. We don't see any crystals. We need polarizing light to see crystals. And when we put the polarizer on an inflammatory synovial fluid, we might see these crystals. On the left side, we see monosodium urate crystals. They're needle-shaped, negatively birefringent crystals. And on the right panel, calcium pyrophosphate, or CPPD crystals that we see in pseudogout. And these are very pleomorphic. So on the left panel, you see monosodium urate. They're all sort of needle-shaped. Sometimes they're very long. Sometimes they're a little bit shorter. But the calcium pyrophosphate crystals are really very sort of varied. So you can see these kind of boxcar shaped, and then sort of these parallelograms. And they are positively birefringent. So you should be able to differentiate these crystals under your microscope in the clinic. And it's kind of fun to do that. Let's talk next about an acute oligoarthritis. So oligo meaning 2 to 4 joints. So infection can do this. And these patients generally don't have bacterial infection, although you can have polyarticular or oligoarticular bacterial infection in patients who are immunocompromised. But disseminated gonococcemia should make you think about acute oligoarthritis. And these patients, as I mentioned, will often have this sort of migratory pattern. Non-gonococcal septic arthritis can do this generally in an immunocompromised host. Bacterial endocarditis can do this. So patients who have infected heart valves can seed their joints in a polyarticular or oligoarticular pattern. Viral infections, reactive arthritis can present like this. Rheumatic fever, as I mentioned, again, this sort of migratory pattern. Some of the spondyloarthropathies can present with an acute oligoarthritis. But as I mentioned, things that were ultimately going to become polyarticular may start as monoarticular or oligoarticular. And then occasionally we'll see patients with crystal-induced arthritis that present with multiple joints simultaneously. It's not the classic presentation, but it can happen. The other thing you want to think about as you're evaluating your patient is, are there other organ systems involved? Many forms of arthritis will have extra-articular features. And the flip side is true also, is that many diseases that are primarily a disease of another organ system may present with arthritis. So you want to be thinking about that when you're evaluating your patient. So rheumatoid arthritis, ankylosing spondylitis, both classically have extra-articular features, and patients who present with inflammatory bowel disease or cancer may have articular manifestations. So a very careful review of systems is very important. So, and that's, you know, sort of generally true when you're doing your complete history and physical examination. You really want to go from head to toe, thinking about, you know, what other organ systems might be involved, and all organ systems should be reviewed. The other presentation that I want to talk about is arthritis with a fever. And so patients who present with fever, our first concern really is there an active infection? And again, septic arthritis should be at the top of your list. Patients with disseminated gonococcemia can present like that. They often will have an associated rash, which can be very helpful. I mentioned endocarditis. Sometimes those fevers can be fairly indolent and low grade and very chronic. Patients may present with acute viral infections such as, you know, EBV. Parvovirus would be a classical one that presents with prominent arthritis and fever, mycobacterial infections and fungal infections. Post-infection arthritis, such as reactive arthritis, particularly in its early phase, and then acute rheumatic fever and post-streptococcal arthritis. I recently evaluated a patient in the clinic. It was a very interesting story. She's a young woman who actually was a friend of a medical student who was in Africa on I was either a mission trip, or she might have been involved in not AmeriCorps, the Peace Corps. She was at the Peace Corps, and she actually developed acute diarrheal infection with fever, and then a couple of weeks later developed this very classical reactive arthritis. And, you know, febrile polyarthritis. And of course, she was in the middle of no place. And, it, you know, she said she ended up on the back of a bicycle with this very nice man who basically took her on his bike to a, you know, a small medical clinic where she was. And then she ended up getting airlifted home with reactive arthritis. And she actually got better. But then a few weeks ago had another diarrheal illness and then presented again with this very classic fever and oligoarthritis, which has been very difficult to treat. So post-infectious arthritis can present like this with fever, and you need to be thinking about that. And it's often missed because sometimes the arthritis will happen long after the infection, weeks, sometimes even a month. So people may not be thinking about that. And then there are some other forms of arthritis that are not due to infection that may present with fever. And these we generally consider after we consider the infectious arthritides, because we don't want to miss those because they're going to be treated with antibiotics and other things like that. So once you've ruled out an infection, you're going to be thinking about other things such as systemic connective tissue disorders, drug-induced diseases, Still's disease. We recently saw a woman in the hospital actually who presented with arthritis and a fever, and went through a million diagnostic possibilities, most of which were a long list of infections. And after we ruled out all of that, we ultimately decided she had Still's disease and finally got her on appropriate therapy, and her fevers have now completely resolved. But it was 3 or 4 hospitalizations and a lot of very careful consideration until we ruled out all the infections that might have been possible, possibly, you know, responsible for her fever, until we found Still's disease. And there are a number of other things, and this list is significantly longer than what I've shown here. This is kind of the top 10. I want to mention the eye because I always want you to ask about the eye. And a lot of times when I ask patients about whether they've had eye disease, they look at me like I have 3 heads, because no one really puts this together in their own mind that a symptom in their eye might be related to a symptom in their joint. But many rheumatic diseases will have ocular manifestations, and there's just a few of them listed here. Patients with rheumatoid arthritis and lupus will often have dry eyes and what we call secondary Sjogren's syndrome. Conjunctivitis is a very classical presentation of reactive arthritis, and this patient actually that I just described that had been in the Peace Corps and then came back to the States who had a flare, she said the first clue that she had that something was going on after that diarrhea is that her eye was very irritated. Patients with ankylosing spondylitis may have a history of acute anterior uveitis or may develop it after their diagnosis. And patients with rheumatoid arthritis and lupus and other connective tissue diseases may have episcleritis or scleritis. So you want to ask about eye pain, eye irritation, redness, previous history of inflammatory eye disease. And it's amazing how many times patients will recall an episode of eye inflammation and they in their own mind haven't put it together. You have to really ask about it. And sometimes the eye disease can be sort of a window onto what's going on systemically. You know, why this happens is super interesting, and I don't think we really know, but there's a lot of analogies between some of the tissue in the eye and some of the tissue that lines the joint. So ask about the eye, very important. And when you're doing your physical examination, don't forget to look at the eye. You know, we're not doing slit lamp exams in our clinic in rheumatology, but we can definitely see if there's pus in the anterior chamber, such as in hypopyon, if there's redness or irritation of the cornea, the sclera, or the conjunctiva, and you can evaluate a patient with your light to know whether there's any iritis. So if you shine a light in somebody's eye and their iris contracts and that causes acute pain, that's often a sign of iritis or uveitis. So there's a lot we can do with very simple tools that we have even in our general medical clinic or in our rheumatology clinic to assess the eye. And if I have any concern, then I'm picking up the phone and talking to my ophthalmology colleagues. Similarly, they may see a patient in their clinic that has anterior uveitis or some other sign that may be associated with a arthritis or connective tissue disease, and they're going to pick up the phone and talk to me. The skin is also very important. And just a few examples here. The patient on the top has this very classical malar rash over the bridge of the nose and the cheeks, and classically sparing of the nasolabial fold. This is a discoid rash in lupus, these sort of erythematous heaped up edges with relative central clearing. This is a patient with psoriasis, which likes to live in the scalp and in the ear canal. So I always tell the students and the residents and the fellows to look in the ear because two things hide in the ear. Psoriasis hides in the ear, and these discoid rashes can also hide right here in the external part of the concha of the ear. So patients will often say that they feel like their ear canal is really itchy or they're having a lot of drainage or things like that. And I have seen many patients with psoriasis present with just that. And then nodules may be present in rheumatoid arthritis or gout, or actually in acute rheumatic fever, although they don't usually occur in the elbow in rheumatic fever, they occur in other places. So looking at the skin can be very helpful. The GI tract, I mentioned inflammatory bowel disease just a moment ago. Patients with ankylosing spondylitis can have inflammatory bowel disease, and patients with Crohn's disease can have arthritis that looks exactly like ankylosing spondylitis. Esophageal dysmotility and also lower tract dysmotility is often seen in patients with scleroderma, so the GI tract should be asked about and evaluated also. Of course, your physical examination is very important, and we're learning to do some physical examination maneuvers on virtual care. It is not ideal. We like to get patients into the clinic and evaluate everything really from their temporomandibular joints to their toes. You want to inspect the joints. You want to assess both the passive and active range of motion, assess for crepitus of the joint, assess for swelling, for soft tissue swelling, for effusions, for synovitis, assess for tenderness, and then look for deformities and decide are they reducible or non-reducible. The patient's complaining of hip pain, yes, you should obviously evaluate the hip, but you'd be surprised what you'll find at the other joints that might help you in making a diagnosis. So a very complete musculoskeletal examination is absolutely critical when you're evaluating your patient. So just a few examples of chronic joint deformities. This is a patient with rheumatoid arthritis here on the bottom. And you can see involvement of the MCP joint with lots of nodules overlying the MCP joint, and then ulnar deviation. On the top is a classical swan neck deformity with hyperextension of the PIP and flexion of the DIP. Early on, this may be somewhat reducible, but over time, it becomes fixed. Sometimes asking patients to wear a little flexion ring that the occupational therapist can make those fingers much more effective and useful and functional. On the right here, we see a boutonniere deformity, which is just the opposite of a swan neck deformity, which is a flexion of the PIP and extension of the DIP. And you'll see that in patients with long-standing and aggressive rheumatoid arthritis. Having said that, because our therapies are so good these days, we don't see as much of this as we used to see, but we still do have patients, or older patients or patients with more severe disease, that you will see some of these findings. These are some x-rays of patients with osteoarthritis of the hands, and these patterns are very, very important. Let me just go back and show you in rheumatoid arthritis, wrists and MCPs and PIPs are classically involved. In and osteoarthritis, relative sparing of the wrist with the exception of the basal thumb joint, you can see that here, but really very prominent involvement with what we call Heberden's nodules, these sort of bony nodules around the DIP joints, and then Bouchard's nodules around the PIP joints. And if you palpate these, they're not squishy. They tend to be very hard and bony. You can't really tell that from a picture, and you can't tell that on a Zoom call, and you can't tell that on a virtual visit. You really have to touch those hands and get a sense of that. So as I hope you've seen, as I've sort of walked through these different elements of your history and physical examination, that there are going to be patterns that you'll be able to recognize. So rheumatoid arthritis is a symmetric polyarthritis, generally involving the small joints, initially in the hands and feet. Sometimes the feet come first. That can be a diagnostic conundrum, but you have to be thinking about that. Ankylosing spondylitis is an inflammatory arthritis involving the back, involving the axial skeleton, can also involve the peripheral joints, but variably so. Psoriatic arthritis can have a very variable presentation and can look like almost anything, but the presence of psoriasis on the physical exam can be very helpful. Occasionally, though, the arthritis starts before the skin disease, and so you really need to know these patterns. So they can have an asymmetric polyarthritis, a symmetric polyarthritis that can look like RA, and they can have an inflammatory arthritis at the back and can look like AS. So you want to keep your differential diagnosis open. We mentioned gout, which is generally, at least early and acute inflammatory monoarthritis, most likely to involve a lower extremity joint in the early phases. But if it's untreated and there's chronic hyperuricemia, it may present with a chronic inflammatory polyarthritis, can look just like rheumatoid arthritis. So you need to be thinking about this. Osteoarthritis, symptoms are not inflammatory for the most part, although not always. There is a small subset of patients with osteoarthritis that may present with what we call inflammatory or erosive osteoarthritis in the hands, but again, usually in the DIPs and PIPs, so that pattern can help you. But osteoarthritis may be monoarticular, so in the case of a post-traumatic arthritis or oligoarticular, or even sometimes polyarticular, can have many different patterns. So to wrap up, we talked about the duration of disease. We talked about the number of joints and the pattern of joint involvement. We talked about the importance of assessing inflammatory symptoms, assessing symmetry, and also a very careful inventory of other organ systems that may be involved to look for both extra-articular features of arthritis as well as primary disease in another organ system that may present with rheumatic complications. So I will stop there and open this up for questions. I think I'm going to also maybe stop sharing my screen so I can see all your happy faces.
Everyone, you are potentially on mute, so make sure you unmute yourself. If you have any questions, you can ask them, and then, or you could type them into the chat box if you would like.
Hey, Tyler here. I was recently talking with a physician here in Augusta and told him that I was studying OA and lupus this summer. And he made an interesting point that potentially we should just change the name from osteoarthritis, just osteoarthropathy, I think is what he said. And you made the point too about it being typically non-inflammatory. I would just love to hear more of your thoughts on that.
Yeah, so we've actually got a number of osteoarthritis experts on the line, but I'll give you my take on this. Sometimes we'll use the term osteoarthrosis. Sometimes we'll use the term osteoarthritis. Please don't ever use the term degenerative joint disease. That will make us all, our heads explode. But, you know, I do think that osteoarthritis, you know, is inflammatory. The reason why I think it got designated as a non-inflammatory arthritis is because if you do a synovial fluid analysis and you look at the number of cells in there, there really are not a lot of cells. So you would think, okay, there's no inflammation going on there. But if you look at the other tissue in the joint, such as the cartilage, there's lots of evidence that there's inflammation going on in the cartilage and a lot of the other tissues around the joint. So yeah, I think, you know, in rheumatology in general, and you'll probably learn this over the course of the summer, our nomenclature sometimes comes back to bite us. And so we want to be as explicit about what we're talking about, and our nomenclature sometimes doesn't help us out there. I can see Amanda's on the line and she's muted, and I'm going to ask her to maybe jump in and if she wants to just give her own 2 cents on this.
Hello. Yeah, so osteoarthritis is arthritis. It's actually quite inflammatory. In some cases, the synovium looks just like RA synovium. So it's really variable. I think probably it's right that the tissue we can access and see doesn't look nearly as inflammatory as some other things like RA or gout or, you know, these kinds of things. So it was used as a control for a long time. They'd say these are the inflammatory people with RA, and then we're going to compare them to OA. Well, that was probably a really bad idea. The more we're able to assess with advanced imaging and really look at synovitis and effusion and get better ideas about what the tissue itself actually looks like, it's much more inflammatory. It's just not as apparent, and it's different pathways than some of the other diseases.
Thank you.
Any other questions from anyone?
All right.
Doesn't look like it. Okay.
I know, that's like so clear. There's no questions. All right.
We've mastered it all.
Yeah, well, I just wanted to say to the students, I know you're here with us for the summer virtually, and it may not be as ideal as being with us in person. We are all here, and please reach out if anybody can help you as you're working through your projects or thinking about career planning, or want to ask me a question offline about this or any other topic in rheumatology. I want you to all feel sort of part of the community, even though we're just looking at boxes on a screen. Sometimes we're here, we're all working, and we're sort of in our mission to help educate you and help you learn about arthritis, and also advance our research goals. So we're here, and we're thrilled to have you here on the line with us this morning and with us for the summer. So please reach out if I can help you in any way.
Great. Well, thank you again, Dr. Jonas, for taking the time to talk with all of us. We're going to be sending a follow-up email to everyone in the coming days with a link to access this recording in case you would like to listen to it again or share it with your colleagues. Please join us again next week on Wednesday, July 1st at 10:30, when our next 101 Introductory Series presenter will be Dr. Richard Loser. He's going to be discussing osteoarthritis phenotyping 101. Thank you again for attending the talk, everyone. I hope everybody has a great day. And also for the students on the line, I'm sending something in the chat. If you would like to be added to our listserv that gives you information about these talks, like including upcoming ones, feel free to shoot that email and just say, hey, add me to the listserv, and I'd be happy to put you on there so that way you don't miss any of them. Okay, thanks everybody.
Thank you.
Bye.